TI. So if you have a patient giving a history of 6 months duration, 2 years duration, then you can almost rule out transient ischemic attacks. So 3 differential diagnoses. Let's say for discussion's sake, we ruled out TI. This is a patient coming maybe 6 months or 2 years duration. You can arrive at 2 possibilities. One, you ask for features of Meniere's, no features of Meniere's. You ask for features of migraine, no features of no family history, nothing. So you have only vertigo, monosymptomatic vertigo. That means there are no associated features. In that case, you have 2 diagnoses. That is benign recurrent vertigo, BRV. This was first described by Slater in 1979. It is similar to vestibular migraine treatment, and all is similar. Okay, I'll come to that. And next is another diagnosis is vestibular Meniere's. Like I said earlier, many Meniere's can occur without the oral features. So how will you differentiate between these 2? You can do a clinical test called the high frequency head shake maneuver. So you take the patient's head and you shake the head in a particular way, and after high frequency head shake, you look for nystagmus. If the patient develops nystagmus, it means that the patient has some permanent vestibular damage, and that will be only in vestibular Meniere's. In BRV, it is benign. There will not be any permanent damage in the vestibular system. So this is how you can differentiate between these 2. Meniere's you treat like you normally treat Meniere's. BRV you can treat like you treat vestibular migraine. Now coming to the other extreme, where you have all the features of migraine, you are about to make the diagnosis of vestibular migraine, and you ask about oral fluid tinnitus, hearing loss patient has that also. So patient has both features of Meniere's disease and migraine, and this is a vestibular migraine Meniere's overlap syndrome. This is a clinical entity, and this is known to coexist. Meniere's and migraine is known to coexist in certain patients. So I checked for references for treatment for this condition. I couldn't find any. So I asked sir. So sir said, Srinivas sir said you can treat it like separately. You treat migraine separately. You treat the Meniere's separately. And depending which is more problematic for the patient, you give treatment for that. Rest you can maybe lifestyle modification, things like that. But this it can exist together. Okay. Now coming to those 2 uncommon conditions in the first group, 3 main diagnoses, 2 uncommon. So keep your eyes open for idiopathic intracranial hypertension. This is not very uncommon. This is actually common, but it's underdiagnosed. When you have these patients coming with the vertigo, ask them if they have pulsatile tinnitus. Interdictal pulsatile tinnitus will suggest a raised intracranial hypertension. Lucid intervals between the attack. Patient starts the attack, and for some time he feels good, and then again the attack starts. So if there are these lucid intervals between, then think of IIH. Then sometimes in the patient, if the vomiting is a prominent symptom, like if the patient moves his head and he vomits, or if he sees something moving, like if you give optokinetic stimulation, the patient will not tolerate that. The patient will start. If emesis is a prominent feature, then think of IIH. Next, little more uncommon is episodic ataxia. If episodic ataxia presents normally, they will have oscillopsia, diplopia, dysarthria, muscle weakness and all. So we'll definitely think of stroke and we'll take an MRI. MRI will be normal, and then the neurologist may make the diagnosis. But sometimes it will be only vertigo. In that case, between these episodes, these patients will have some oculomotor abnormalities. So if you ask the patient to look straight and you observe the eye, there will be a downbeating nystagmus. If you ask the patient to look to the right, there will be a right beating nystagmus. You ask the patient to look to the left, left beating. So there will be gaze evoked nystagmus, straight gaze, there will be down beating. If you ask the patient to follow your finger, they will not be able to smoothly follow. They will have this saccadic smooth pursuit. And they will not be able to fixate, suppress their vestibulo-ocular reflux. That you put them on a rotating chair and ask them to look at the finger and you rotate. So they will, normal people will be able to fixate on the thumb. But these patients will have that nystagmus when you turn the chair. So these 9 out of 10 patients will have these abnormalities in episodic attacks. So if you get these, it is rare to get them, but if you get these between attacks also, then you can be sure that it is this diagnosis. Okay, so that is the first group. Now coming to the second group. Second group is recurrent, spontaneous, short-lasting vertigo. That is, it is less than 1 minute. Okay, so 1 minute, 2 minutes, and patient gets these attacks repeatedly throughout the day. Patient is normal, he is working, suddenly he feels giddy, then he is normal again he feels giddy. So repeated, and this is a symptom of vestibular paroxysmia. If it happens in toddlers, what will happen? They will be playing, the child will be playing, suddenly the child will get up, go and hold the mother, or they'll just clutch something and they say that the room is spinning. and then they'll be normal and they'll continue playing. So repeatedly they'll have these, they will say something that their head is paining, because they won't be able to explain. And if you get the symptom, you can safely make the diagnosis of benign paroxysmal vertigo of childhood, BPVC. But only thing is, before you make this diagnosis, you need to rule out a neonatal seizures, because this will also, neonatal seizures also present like this sometimes. And just do an EEG. If EEG is showing no features of a seizure disorder, then maybe the diagnosis BPVC. And this is actually a precursor to adult onset migraine. Remember I told you that you can ask childhood manifestation. Children like with BPVC and all in adulthood, they might present with vestibular migraine or migraine. Now, how you treat? Generally, it doesn't require any treatment. It is benign. If the symptoms are very debilitating, you can start cyproheptadine. Teenage, if it presents in teenage, then most probably the pathology is root entry zone compression. Suppose the vestibulocochlear nerve is entering the brainstem, there is a vascular loop. And if there is a vascular loop, then this presentation will be in the teenage age group. If the vascular loop is in the internal auditory canal, then it will be in the young and middle age group. If it presents in the elderly, then think of vertebro-basilar dolichoectasia, that is tortuous and dilated vertebro-basilar vessels, which will cause these symptoms. Now, how will you manage these other adults? The drug of choice is carbamazepine. In adults, you can add, in elderly, you can add ecospirin with carbamazepine. So when, as soon as sir said carbamazepine, people in the audience said, sir, we don't want to give carbamazepine, or what if the patient does not respond to carbamazepine? So then again, this one of the neurologists said they gave all these. So before I go to the next slide, all these age groups also think of migraine. And above 40, again, transient ischemia attacks is a differential diagnosis. Okay. So these were the alternatives to carbamazepine that she suggested. If you have a patient who is not responding to your migraine treatment or your vertigo treatment, stop the treatment, give a short course of steroids, and then restart. Sometimes the patients will respond. So giving a short course of high-dose steroid will help. Other drugs you can try is oxcarbamazepine, gabapentin, nortriptyline, pregabalin, nortriptyline, phenytoin, lacosamide, lamotrigine. I told this, I think only lamotrigine has the same problem as carbamazepine, the skin rash problem. The rest of them have a better safety profile. So some patients will respond to these drugs. Now coming to the third group. Third group is recurrent, immediately trigger, short-lasting vertigo. The difference between this group and the first two are, the third group of patients will definitely tell you that I am doing this and I am getting vertigo. And whenever I am doing this only, I am getting vertigo. So they will give you a specific trigger, which will be a clue to diagnosis. The most common thing we know is BPPV. If there is any head movement in relation to gravity, that is, if your semicircular canals are moving in relation to gravity and the patient is getting this symptoms, then it is BPP. Like rolling in bed, bending forward, backward is fine. But this kind of a movement is not likely to produce vertigo in BPPV. If the patient is turning the head to one side like this, and then he is getting vertigo, most likely it is a rotational vertebral artery compression syndrome. The syndrome is also known as bow-hunter syndrome, because the bow hunters, they used to do this. So when the patient turns the head like this, the opposite side vertebral artery gets compressed. And I think after this course, I've noticed two patients like this with similar profiles. But I told one patient to take MRI, they didn't take. The other patient, I lost a follow-up. So I don't know if it is exactly this kind, but the symptoms are very clear. You ask the patient, any position, you do the position maneuvers, you do everything, patient is normal, no vertigo. But you ask the patient to hold the head position like this for some time. Then they will say, no, I'm getting blacked out, I'm going to fall, I'm feeling giddy. And then you turn the patient normally, it will stay in head, they'll be fine. So, rotational vertebral artery syndrome, you may be able to pick up. Then, getting up from supine or sitting position to standing makes the patient vertigo. They have pulsions or dizziness. Going back to sitting and sleeping, they are normal. That is orthostatic hypotension. Exercises of the upper limb will make them giddy. That is subclavian steal syndrome. Then touching the neck while shaving, or when some pressure in the neck, that is carotid sinus hypersensitivity. Only during head motion. The patient has vertigo only when they are rapidly moving the head. That is vestibular migraine. Then this last point, actually I added after this, it was not in sir's original presentation. This is, the patient has a problem only when driving. The patient, actually the profile of the patient was, he was a driver for many years, and recently he noticed that when he is taking left turns, he feels that the car is going straight. Or when he is taking a right turn, he feels that the car is going more towards the right. And then he feels very panicky, he's sweating, he has to put the car on the side, wait for some time, and then drive. He's been driving for many years now. It just started only recently. And when this person put this discussion in the group, the one neurologist from Dubai, Dr. Vishal Pawar sir, said he has a case series of 30 such cases. And the problem happens only when driving. No other time. Other time when he moves his hands, when he turns his head, nothing. Only when driving. So now they recognize this entity called motorist vestibular disorientation syndrome. And then obviously people in the group asked how you manage this. So sir had said you can try pregabalin, nortriptyline with magnesium. Magnesium 100 mg OD tablet. But sir usually uses magnesium as a prophylaxis for migraine also. So maybe other drugs for migraine prophylaxis also might work for these patients. So this is one new, not new, it was known before, but now it's more evidence is supporting that condition. Falls. Falls is actually a large topic. I just picked out the part that is concerning us. When a patient comes with falls, the first thing that you need to do is find out whether the patient has a loss of consciousness or not. How do you do that? Never ask the patient. Just ask them to reiterate what happened. You fell down, somebody picked you up, took you to the hospital, you had food. So somewhere in this description, there will be a lacunae. And there you can probably guess that the patient had some LOC. So never ask the patient. Now if it is with the loss of consciousness, think of 4 possibilities: syncope, epilepsy, syncopal migraine, and conversion disorder. Okay, I won't go into the details of this. We are more concerned with without loss of consciousness. Just before that, if you have jerks, abnormal jerks, it doesn't always mean seizures. In syncope also you can have jerks, but the difference is in seizures, the jerks will start before the loss of consciousness. In syncope, it will be after LOC and it will not last for very long. It will be around 10-15 seconds, just maybe 2-3 jerks, and then the patient will come back. So that is syncope. Headache and fall. Ask the patient whether they had headache before the fall, then it suggests syncope. If the patient developed headache after on recovery, then it's probably seizure. Eye deviation, uprolling of the eye, then probably syncope. Horizontal deviation, probably seizure. But you will have to be present there in order to notice all this, whether it is syncope or seizure. Flaccid falls suggest syncope. Stiff falls, usually seizures. Now this is where we are interested. Falls without loss of patient's consciousness is absolutely preserved. If they fall like a sudden paralysis, like all the muscles suddenly give way, that is cataplexy, seen in narcolepsy and all. Vestibular falls will usually be high velocity falls, energetic falls. They will say that I felt that somebody pushed me to the ground. So those are vestibular falls. And vestibular falls, you have 4 diagnoses. 4 vestibular diagnoses can cause falls. So one, we know Meniere's disease, we all know Tumarkin's autolytic crisis. In late Meniere's, you will get this kind of falls. BPPV is a cause of fall, and especially elderly age groups, now they are saying that undiagnosed BPPV is probably one of the causes for falls in elderly. So rule out BPPV. Vestibular migraine can cause falls. Vestibular paroxysmia can also cause falls. So 4 diagnoses for vestibular falls. Predominant difficulty in walking. The patient may have any number of complaints, but if you ask them what is your actual problem, it will be a difficulty in walking. So bilateral vestibulopathie is one diagnosis that is underdiagnosed. We easily diagnose presbyacusis, but presbyvestibulopathy, where the patient has an age-related loss in vestibular function, we don't diagnose that commonly. Presbyvestibular, how will it present? The patient will come to you and tell you that when I'm walking in the night, when the lights are switched off, I'm having difficulty. When I'm walking on uneven, unfamiliar surfaces, foamy surfaces, I'm having a little bit of problem. Then they'll say one of the main functions of the vestibular system is gaze stabilization when you rapidly turn your head. So when they are moving in the car, they will not be able to fixate on anything. So they won't be able to read signs. So the patient says, when I'm driving, I'm not able to read signs. I have to stop the car and then read the sign. Or when I'm jogging or walking, I'm not able to recognize faces. Or I'm not able to read boards. These are the kind of symptoms that the patients with bilateral vestibulopathy will come to. So then think of that, and you can actually make a diagnosis easily with the caloric test. I scored caloric. If you irrigate, you can make if the vestibule is functioning correctly or not. Then next thing is CP angle lesions. We know just like sudden sensory neural loss, it can also cause sudden vestibular loss. When you are taking an MRI for a patient who has predominant difficulty walking, also try and do a screening spine, because dorsal column lesions, demyelinating lesions, peripheral neuropathy, diabetes, malnutrition, all this can also cause difficulty walking. Then motor weakness, cerebellar degeneration, limb length disparity. If they had surgeries in the limb where the limb length is different, they were not attributed to that, but the actual cause is because their limb is probably a few inches, the length is different. Then frontal gait disorders, extrapyramidal disorders. So I think the first three is more important to us. So difficulty in walking, you can manage like that. Then first episode of vertigo dizziness. This is the condition that will bring us to the casualty. Okay, patient comes. So whenever you think of vestibular, don't forget that chronic otitis media complications also will cause vertigo. Next thing is cerebrovascular accident. Only 2 points in that. One, usually in a posterior circulation stroke, hearing will be preserved, except in one type of stroke, that is anterior inferior cerebral artery stroke. ICA stroke, only the hearing will. Otherwise, if you have hearing loss sudden onset, vestibular loss sudden onset, usually it is not a stroke, it's not a central problem, it is a peripheral problem. But you have to rule out this ICA stroke. Then, sometimes the patient will come to you sitting and they will say giddiness, sweating, vertigo, and you will think of all this, but the problem will be a ruptured duodenal ulcer, or a ruptured ectopic pregnancy, or a ruptured appendix. Because sometimes the pain and all will be masked and the patient will have only giddiness. So think of any hypovolemic conditions, especially in the casualty, think of other systems that could be involved. Post-viral demyelination and cerebellitis, especially in children. Actually, there was one case in medical college only. The child was absolutely normal. He jumped on the merry-go-round. After the merry-go-round, patient cannot stand. He is like a drunk person. Consciousness is preserved, he's eating, he's talking, everything is fine, only he cannot stand. He's just moving like this. So I didn't see the patient, I think Sapna madam saw the patient. And then when I asked her about this, what could this be? So he said probably it is post-viral cerebellitis. The fever may not be a prominent thing, but the child will suddenly develop these kind of funny symptoms. It's probably demyelination or post-viral cerebellitis. BPPV, we all know, can have an acute presentation sometimes. Then vestibular neuronitis, labyrinthitis, we also know. Sometimes convergent spasm will also produce what they will not tell you about the diplopia or the other features. Only the only symptom that they will say is that I'm having giddiness, especially when I'm trying to follow some object with my eyes, they will have this problem. So convergent spasm is also one cause for vertigo. Coming to the last group, the chronic persistent dizziness. Now, these patients, they will be dizzy all the time. And you notice that all the other symptoms, vertigo and dizziness, here it is chronic persistent dizziness. So dizziness, the patient will not have a rotatory sensation or a sensation of motion. It will be just some uncomfortable feeling. You ask elderly patients, when they're sitting, they're having problem, they're lying down, they'll have problem, while walking, they'll have problem, all the time they have this, some sort of problem they have. So these, earlier it was known as phobic postural vertigo, PPV. Then they renamed it as chronic subjective dizziness, CSD. So finally, Barney Society now has classified it in an umbrella term called triple PD, or persistent postural perceptual dizziness. And this is one of the most common diagnoses made in elderly individuals. The basic thing what is happening is, maybe the patient had a BPPV episode and or a vestibular neuronitis, and our body makes some kind of behavioral adaptations so that the patient, it is a safety mechanism. So like if it is BPP, the patient will not turn his head very quickly, they will walk very slowly. This is till the time that vestibular insult lasts. After the patient's vestibular insult recovers, the patient usually will shed off all these behavioral adaptations and then become normal. Some patients will fail to shed off these these adaptations, and then it becomes maladaptation. So even after the vestibular problem is solved, they will still turn their head very slowly, they will walk slowly, they will become anxious. So this will slowly develop into a triple PD. So the initial problem is solved, but they have this psychiatric or psychogenic problem. So here you can give clonazepam or anti-anxiety drugs for a short period of time, and you need to reverse this maladaptive behavior. That is why you have to give tailor-made vestibular rehabilitation therapy. Some patients they'll be scared to climb upstairs, so you make them walk upstairs, build their confidence. Give this, you can give SSRIs also, escitalopram, you can give duloxetine, SNRIs. So these and all work well with labyrinthine exercise. So this is how you treat triple mean. But it's easier said than done, because these patients, even if they respond to it, after some time they'll relapse. So each time you need to sort of boost their confidence, continue the rehabilitation therapy. Recent onset persistent dizziness, think of all the other medical causes. If you want to investigate the patient, then do all these investigations: anemia, thyroid profile, renal failure, liver disease, electrolyte imbalance, bradyardia, not getting anything. Then try and investigate and find any other causes, probably diagnosis. So that we come to the end. I hope